Before your presentation starts, I'd like to take a few moments to introduce you to the City of London Dental School. We're a private postgraduate dental school based in London and run from our college facility at Southgate. Here we offer a number of various programs, both short and degree programs. At present, we offer 6 MSc titles validated by the University of Bolton. These include clinical dentistry, orthodontics, periodontology, pulpal therapy and endodontics, restorative and aesthetic dentistry, and the specialist practice of restorative aesthetic dentistry combined with implantology. These are delivered from our state-of-the-art teaching facilities, and to be introduced shortly are 3 more new titles. We're also introducing the MSc in the specialist clinical practice of aesthetic non-surgical interventions. This is to do with facial cosmetics. The MSc in the specialist practice of computer-guided implantology. This is implantology taught from a digital perspective. Also a combined MSc of restorative aesthetic dentistry with implantology. These programs are all taught from our laboratories where hand-on experience is required, where delegates get the opportunity to use the latest digital equipment, printing materials, scanners, and also to practice prep techniques on phantoms. Our short programs are in topics such as implantology, restorative and orthodontics. These programs normally last anywhere between 4 to 12 months. We also offer clinical internships in the UK and the UAE, where delegates get to treat patients directly. In addition to this, we offer diploma and certificate programs. These programs are at HE level 7, so they're university certificates, which means that they can be used towards MSc programs, not just MSc programs that are offered by the City of London, but also other programs. So thank you for sparing the time to listen to this presentation. If you want any more information, then please contact us at info@cityoflondondentalschool.co.uk. I hope you enjoy your presentation today.
So minimal intervention techniques in cosmetic dentistry. I did a version of this that the BAC did, the British Academy of Cosmetic Dentistry, and it was our 15th anniversary when we had the past president meeting. One of the things I did know about 15 years ago. I am past president of the British Academy of Cosmetic Dentistry, and I'm accredited by the BACD, which, as corny as it sounds, is not a destination but a journey, and that journey undoubtedly made me a better dentist by reviewing everything, but I do believe it's an achievable standard. So a few disclaimers. As I said, BACD past president and accredited. I am a GDP. I've been qualified 31 years, and 23 of those years were in the same practice. That really tells you what works and what doesn't work. And so that's really why I'm so passionate about minimal intervention, achieving great cosmetic results, but without having to destroy a lot of tooth tissue, if at all possible. I use anterior orthodontics, cosmetic orthodontics. I happen to use CFAS Smile True, but CFAS is a brand. There are many other brands out there. Quick Straight Teeth, 6-month smiles. IAS do a version. I happen to be affiliated with CFAS, but this is not a paid presentation. No one is sponsoring this. So these are just things that I use. And similarly, I use many DMG products. I think they're a great company. They're not sponsoring me. I may mention other products. It's just that a lot of what I use does involve DMG products. So really, the purpose of these pictures is just to show how things change over time. And we all know kids grow up. It's not without their challenges on many levels, but it's really about how things evolve and change. And that's why whatever we do is going to have a lifespan. Whatever So the less we can do to a tooth, the better. And I would quote longevity really of porcelain restorations, 10 to 15 years. So if you're doing that in a young adult, they're going to have a number of redos in their lifetime. So I think it's important that we are responsible in how we respect tooth tissue. So I think it's important we also remember that not everything is a 10-unit veneer case. Far from, in fact, as hopefully I will show today. This is a single central, a large composite build-up. The patient was a referral to me. I think in this day and age, as she was a teenager or certainly early 20s when she was referred, I would advise her that that lower anterior crowding is likely to get worse with time. I think it's important we're making notes like that. Otherwise, the patient could come back and say, well, you never told me about that. Whether they choose to do anything, but at least we're advising them. But obviously, patients come in for the upper left central. That's the result. This is the result at fit. Patient was a referral patient, never managed to get the patient back again. So that's why I don't have any updated photos. And this is where this is at insert. But with a good lab communication, that is possible, not always easy, admittedly. But I don't think that's a reason to treat more than one tooth. And now with the advent of eLab, I think it is getting easier to get these results, although it's still I think we should also remember our bread and butter dentistry, upper left 6, small DO. Access that bottom right here. This is before we refine the margins. I'm old enough to remember enamel chisels, but we can still do that. We want to make sure we have no fine edges of enamel. A sectional matrix, you can see that's tidied up. Single layer, build up. And again, my point here is attention to detail. This with a small soft flex disc, we can take to here in a matter of seconds. And I think it's very important that we do have that attention to detail to just smooth those edges, because that's going to help the restoration. I'm a big fan of indirect restorations. I do direct as well. I think that upper right 6 would benefit from palatal cuspal coverage. I think the 4 is also in realms of an onlay. The 7 could probably be done directly. However, we've got some undoubtedly some fracture lines happening here. So in fact, I did all 3 in direct. I think nowadays a lot of people may choose to do some of those direct, which is fine. But I think we need to be aware of indirect restorations as being much more conservative than full coverage crowns. I still do a lot of full coverage, but if possible, I will maintain more tooth structure by doing an onlay, usually indirect. So if we look at some of the avenues we have, whitening, and I can see support is in with us. Thank you for all your help in getting that legalized for us. Anyway, whitening, both external and internal. Very few of my cases don't involve some degree of tooth whitening, and I will talk about that. Icon happens to be a product by DMG that can help with white spot lesions. I've got a case that we'll discuss that. Enamelplasty has its place. I think limited. If a patient comes in with a slightly chipped central incisor and asks me to smooth the other one to match, I will decline because I believe they'll end up with too shorter front teeth. But the lower incisors, often after alignment, a little bit of enamelplasty, but equally well, a lot of composite bonding, edge bonding. We're going to talk about composite veneers and a system that is making that a lot easier now. Porcelain veneers, obviously. Anterior tooth alignment, short-term ortho, limited treatment outcome, orthodontics, whatever you like to call it. We're going to talk about that. But that's been a massive change for my practice and means that I still do a lot of veneer work, but I do a lot less, because often at the end of that ortho, if we're whitening and some simple edge bonding, or even that ortho might mean pre-alignment so that everything is 100% enamel. And I won't do a veneer if it's not 100% enamel. So CFAST is the system I use. I think we should bear in mind soft tissue contouring, both soft tissue, just with a diode, or with raising a flap if we need to preserve the biological width and we don't have the excess biological width to allow us to just laser away the gingivae. Obviously implants, we're going to look at a reverse frenectomy. And we should be aware of Botox and fillers and osteotomy, although I'm not going to be including the last two in this presentation. So if we start with Icon. So patient, young man, just 18, which happened to help because we did choose to whiten, being referred in with this white spot lesion. Now, the thing about these white spot lesions is we can look at their diagnosis, but it's sometimes difficult to get a confirmed diagnosis. Icon is going to work well if the layer is superficial. There are many colleagues who do far better presentations devoted just to Icon. And what you'll find is Icon is, well, first of all, if we look at Jamie when we did some whitening, we know that we're going to have to replace the upper left one composite. But I always feel that if we can do whitening initially, we're going to improve the situation. So this is standard a vital tooth whitening. Personal preferences, there are many different designs of trays, different gels. Some gels more expensive because the manufacturers spend a lot of time maintaining it by refrigerating it because they believe that helps its efficacy and its efficiency. I don't dispute that. For me, the most important is the tray design, and my preferred method is to have a seal at the gingival margin. So I will ask the lab just to score, or even make them in-house, score the gingival margin to allow effectively like a seal, a post-dam seal, and then a suck down. Myself, I don't use reservoirs because I find that it's easier to manufacture tray without, and I don't scallop. I just do a straight cut, 2 to 3 millimeters past the CEJ, knowing we've got that seal. There are other designs, and colleagues will say that the literature doesn't give any evidence of better results for one design or another. Empirically, my preference is to have a sealed gingival margin. And you can see the results we're getting there, and it's already reducing that contrast. Then Icon is, it is a hydrochloric acid, so I think we need to be using rubber dam to isolate the tooth, and then hydrochloric acid over the white spot lesion, and that's going to remove about 100 microns, about 10 microns. And so the manufacturers will be saying you can do that 4 to 6 times. I know some colleagues have done it more passes than that. You apply the hydrochloric acid, you put Icon Dry, which is essentially ethanol, and that mimics the final result. And if the result is good enough, that's great. If not, you can repeat it 4 to 6 times. Some colleagues are doing it more than that. If you're doing it more than that, I think you need to be prepared that you're going to need to place some sort of composite because you will be removing some tooth tissue. Colleagues will deliberately remove tooth tissue, knowing that it's very deep, and then they'll use Icon to help the refractory properties. But really, that depends on the depth. For this case, we decided not to do any drilling at all, but I did place some composite afterwards. And effectively, that composite is prouder than this because we did no drilling. But I think you'll agree that the zero tooth preparation, apart from the small degree that Icon will remove, a pretty good result. And we haven't drilled the tooth at all. So Icon very much has its place. We don't always need to treat a lot of tooth. So patient here was a rep from one of the dental companies. She was American. She came over and she'd never really liked her smile, but she didn't know why. And I think the answer is, whilst some degree of incisal dominance is important, she has too much incisal dominance. Now, there's no doubt that we can build up the lateral incisors, but I actually feel that probably the proportions of these centrals are a little bit much. This is a combination case where I would propose a little bit of enamelplasty on the edges of the centrals and a little bit of build-up on the laterals. The build-up on the laterals we can mimic with some composite. Here we can take a black felt tip, as our American colleagues would call it, a Sharpie, and we can just black out that area and demonstrate without doing any tooth removal to the patient what that can look like. And once we have consent, we can look at building up the laterals and shortening the centrals. So here we've done a little bit of shortening on the centrals already, and here is just some mock-ups on the laterals. I didn't take a photo with the Sharpie, but I demonstrated that to the patient first. And then we've got our final result. We can talk about the gummy smile later in the presentation. I will look at what options we have to treat this, but already things are more in harmony. Again, zero tooth preparation. Some advocate tooth preparation for edge bonding. Personally, I prefer not to. If I'm doing class 4 restoration, there's already been some degree of damage to the tooth, then I feel better about putting a bevel on. But I find for edge bonding, in cases like this, I don't need to put a bevel on. I think the secret is to have a brush, and in fact, there are now silicone brushes which are available, which means we don't have to worry about how we cross-infect, control our brushes, silicone brushes, and we can literally brush into the surface and get an infinity margin. The composite is going to go beyond the edge of the margin, but if we can polish that down, then we don't need any tooth preparation. It might be just a patient, as we look at the case, we'll see why a previous colleague had decided to try and put some composite over that. Problem is that obviously they didn't have all the shades that they might have needed available, so I wouldn't be quite so confident about their shade choice. But sometimes it's simple things. Remove the composite. That's all we've done at this stage. So this is pre-op for the whitening. We can see our shade tabs. Some advocate taking one with the canine, because canines are generally going to be a little bit darker, and that can help show that to the patient in advance. But you'll see there is a little bit of pitting on the centrals, which is presumably why they'd chosen to put some composite on there in the first place, and just some simple tooth whitening. We made the decision, actually, we didn't need to put any composite on for the pitting because it wasn't bothering the patient. So again, be aware of the simple treatments. Before and after, and here you can see the pitting is a little bit clearer, but patient was quite happy with that. Sometimes it might involve just a little bit of composite bonding. Here we've got a small chip, a little bit of whitening, a little bit of edge bonding. Actually, it's a class 4 restoration, quite a few years old. Again, I would now discuss the lower anterior crowding, and we can see how easily that can be corrected, either with fixed ortho or even with aligners. So I'm going quickly because we've got quite a lot to cover, but so far relatively straightforward cases. Internal bleaching very much has a place. My only concern is how stable it will be, but I think it's certainly worth trying. This is an 18-year-old patient, a female, who had traumatized this, and it was non-vital, it was root fill. I think it's important to remember that sometimes patients, certainly older, will come in with a single dark tooth closed canal and it's still vital. And in that case, I will try external whitening. It's about the only time I will use a reservoir. I'll use a reservoir front and back to buckle in lately because I want to bathe that tooth in peroxide, and I'll only be planning for the patient to whiten that one tooth. And we can get some great results rather than having to electively root fill the tooth and then internally bleach it. So this is a non-vital case, but sometimes for those dark cases where they've had tertiary dentine laid down, again, external whitening very much in place. For this patient, that's the result we've got. And my technique, I would love to seal in the peroxide, but with legislation currently that isn't permitted. So I will remove the GP to 2 millimeters below the CJ, and in fact that would be the same even if I was sealing in some bleach, some peroxide. 2 millimeters below, and I provided glass line on a plug. Any evidence that there's ever been of root resorption, whilst it is a small risk, is greatly reduced and pretty much eliminated as long as we can prevent the peroxide getting onto the root surfaces and into the PDL. So that plug is going to prevent any peroxide getting onto the root surfaces, and so really reduce and eliminate pretty much the risk of root resorption. And then if I was sealing in, I would then seal in a mix of peroxide, but now legislation passed, so I will do what Martin calls the technique. And basically, I'll leave that tooth open. The glass armor protects the root filling, so we're not going to get any leakage. And I'll instruct the patient to change, I'll make a whitening tray, and instruct the patient to change the peroxide inside here, and inside that one tooth every 2 to 3 hours. And I would expect the color to bleach out in about 48 to 72 hours. It's fiddly for the patients. I give them a hypodermic, I tell them to syringe it, and then put the gel inside the tray and inside the tooth. I can give them some pledgets if they're concerned about getting food in there. And often, for 2 or 3 days, I'll say they can even eat with the tray in, but without any gel, if they're worried about getting anything inside the canal. So we can get some good whitening results. The concern is how stable that is, but it certainly is worth a try. And here we've got a slightly older patient. Again, 2 very dark teeth. Here, and then once we've got the color where we want it, I would put a temporary restoration in. I let the patient do any other whitening if that's what they want to do. And the patient did try to do some more whitening. And then 2 weeks after they finished, I would place the composite restoration. With the oxygen-free radicals, we shouldn't be placing composite in 14 days of whitening. And again, just to show you what simple whitening can achieve, it's not perfect. And in fact, the patient originally intended planning to replace the lower bridge to match these. And I think now if we replace that lower bridge, that would be a pretty adequate result, unless obviously he wants further enhancement with regards to smile design. So how can we show patients how things can look? Imaging has a place. We're going to look at that. Certainly with our digital smile design, that can help with facially driven aesthetics, but it's still a steep learning curve. So I'm going to show some slightly simpler ways, and composite mock-ups definitely, and I've got numerous examples we'll look at, can very much help the patient move forward in that journey. I stress to the patient, I'm not trying to sell anything. My job, and I'm passionate about cosmetic dentistry, is showing them what I see in my mind's eye. And if I can demonstrate that to them and they like that, that helps them move forward. And I'll ask their permission if I can show them something. It's really entirely up to them. But my aim is to move them forward to a visual diagnostic try-in, which is made from a wax up. Generally, analog wax up, but obviously that can now be done digitally. And then I'd recommend you build up your case examples. Again, just trying to demonstrate to the patient what I can see, because I visualize and that's what I do. If they like that, great. If not, entirely up to them. I just want to show them what's possible. So, imaging. Imaging can work. This is a case that's been imaged, and we'll look at the actual dentistry. The problem is, is it always achievable? And if it's done with DSD, digital smile design, possibly more so, but if we're photoshopping that, it may just be a Photoshop that isn't achievable. And also, whilst it is powerful to see that, and certainly in the video, I believe it's much more powerful to actually have the patient see that in their own mouth, which is why I'm going to use some of the techniques that I use. That's the case that's imaged. That's the completed case. I think in this day and age, I would change that. I certainly wouldn't be just doing veneers on those lower incisors. But I know that because we're additive on the outside and we've added here, this is still minimal, relatively minimally prepared teeth, but I wouldn't dream of doing that now. I'd pre-align them. The likelihood is they probably wouldn't need anything restorative. But that's how things move on. And this case was probably about 18 years ago now. So it can be a steep learning curve. It may not be achievable, and the patient is generally looking at a picture, not a 3D and a 3D simulation. So as I said, my aim is to get the patient forward to a visual trial. So how can we help the patient move forward to a visual trial? Because that involves a wax up. I charge for my wax up. I charge laboratory fees plus surgery time. So a 10-unit wax up is going to be in the region of £700. If it's smaller number of units, it's less. So that's a fair financial commitment from the patient. And really, how do we help them to move forward? And I also stress that a wax up does not commit them to doing the dentistry. It commits them to the cost of the wax up. They own the wax up, they can take it with them, but I want them to see what's possible. So to help them move forward to that wax up, we can often just use some composite. I can show you some more refined cases. Patient had concerns about the diastema, quite a flat, even reverse smile line. These are some bridges that have been in many years by me. And the patient was generally happy with the colour. So I wanted to show what we could achieve by just lengthening. Could it be done with composite? Possibly, but this was again probably 20 years ago now. And there are composite techniques that I'm going to show that can help with that. Composite is never going to last as long as porcelain. It's going to have reduced costs, but reduced longevity. As everything, our job is to give the patient the information so they can make the choices that they feel are right. So we can discuss composite as an option, but here we've just got Kathleen with 4 units mocked up, and this is Kathleen's final result. I think it's important when we look at this picture, we realize that in fact when I've taken this, I've had the patient shooting up, so it looks like there's a reverse smile line. As you can see from the full face picture, just 4 units, goes in the diastema, and I'm going to show you techniques how we can make sure that this is very minimal with an additive wax up. So that's Kathleen. And again, other mock-ups. So Sonia, missing lateral incisors, some degree of wear on her anteriors. You can see a fair amount of abtraction, showing her what things can look like. So I said we can just look at doing some bonding on the mesioincisal embrasures of those lateral, of those canines, laterals. Some people would even advocate potentially enamelplasty mid-facial to reduce the bulbosity, and we can turn the 3s into 2s. But we still really haven't got much incisal dominance. So we said they're 2 triangular here, but we said we can even look at doing just 4 incisors with porcelain to give you a little bit more incisal dominance. But she didn't like the rotations here, she didn't like the abtraction lesions, and she wanted to go quite wide. So this is how Sonia moved forward. These are the preparations. Again, many years old now. I would now not be using cord for equigingival margins. I'd be using retraction paste. Historically, that was Expasil. I've now moved on to DMG, doing retraction paste. These are her temporaries. We can modify her trial smile. I would emphasize the difference between a visual try-in, which is from a wax up and involves no tooth preparation. A trial smile is what the patient leaves with to preview their final result. And the trial smile can be modified, but as you can see, we're aiming for our final restorations to be a copy of the trial smile. So Sonia's moved forward from there to there. So how do we get to a wax up? And historically, the technique would be for a reductive wax up. The problem with that is that we end up doing probably more tooth reduction than we need to. But if we look at a reductive wax up, the lab are going to look at the model, they're going to say, right, we need to do a veneer preparation on each tooth. So they'll prepare the tooth for veneers before they do any waxing. The problem with that is that they're maybe making space where they don't need to make space. And whilst that can be very accurate, and here we'll see a copy of the laboratory wax up and the laboratory tooth preparation and my final veneer preparations, they're very similar. But that's the wax up. Do we need to prepare the teeth to make space? And the point being, the more we can add, the less we have to take away. So if I explain to a patient that a veneer is 0.5 millimeter thick, if we can add 0.2 or 0.3 of a millimeter to the facial surface, we only have to reduce the tooth 0.2 or 0.3. And since I started using additive wax ups about 15 years ago, I have not met a single patient that cannot have 0.2 of a millimeter added onto their facial surfaces and have things too bulky. If we can add the whole 0.5 millimeter, we're in the realms of a prepless veneer. I don't really consider any veneer to be truly reversible, because to remove it, whilst some videos are out there of using erbium YAG lasers to pop them off, that doesn't always happen. I've tried it, and if you're removing a porcelain veneer that's bonded to enamel, you're going to be cutting it off. The reality is we're probably going to be scarring you with that. So I don't think anything, even a prepless veneer, is truly reversible. So patients need to be aware of that, but it is important we can do as little to prep as possible. So how does an additive wax up work? Well, we add facially. How much do we add? if a patient comes in asking for a prepless veneer, and there are brands of those out there, Lumineers being the best known brand, patient asks me, do I do Lumineers? No. Why? Because I choose not to use the lab that I have to use a branded luminaire. But any lab can make a prepless veneer by adding to the facial of the tooth. If they're adding the whole 0.5, we're in the realms of a prepless veneer. We'll look at some prepless cases. The thing is, sometimes you add a 0.5 and the patient looks too, the veneers look too bulky. And if we do a visual try-in, we can then explain to the patient. The patient says, well, they're great, but they look bulky. And that really gets the patient buy-in to why sometimes you have to do some tooth preparation. However, generally, I'm not trying to do prepless. I'm trying to add 0.2 or 0.3 so that I have to reduce the tooth less. And you can see here, we've built this up, and this is our wax up. And we then have a stent. There are very many different types. Just a facial buccal stent. And you can see here how we are being able to add to the front of the teeth and therefore have to reduce the preparation. And I will show you how we do this as a visual try-in to confirm that things aren't too bulky before we even touch the teeth. So we make a putty matrix, and this is what I would call a V-notch putty. Often now I'll have this relined with light body. Certainly from the digital wax up, we're getting a lot of more surface texture, although a skilled laboratory technician can put surface texture on if you want, and you wax up, and then we can record that. And then we'll be able to do our try-in. So a visual diagnostic try-in involves no tooth preparation. So this is Shane. And Shane is probably one of the first cases that I did like this. And Shane attended saying he felt he had small teeth, gaps in his teeth, and what could we do about it? And you'll see when we look at the occlusal views and the lateral views, so we've got some quite big spaces there. And I wanted to be sure that we could close these spaces and not make these teeth too bulky. Could we have done 4 units? We possibly could have. However, he did want to go quite wide, and he didn't like the spaces here. So we're then doing more units. Personally, I'm not a big fan of 8 veneers. I think if we're doing a full smile, most patients will show 10 units in their smile. The extra costs, if it is an option, an issue for the patient, we have various options. We can do the extra 10th or even 9th and 10th unit at lab fee or at a 50% fee, whatever you feel is appropriate. But I think it's important we're trying to get the best result, and I'm not thinking just financially. So here, this is the additive wax up from the laboratory. And here we have the lab indicating where they feel there needs to be some laser recontouring. And that's really going to help the emergence and the shape of the canines. This we probe for biological width. And as long as we've got more than 2.5 to 3 millimeters until we hit the osseous crest, we know that we can remove a small amount of gingiva, leaving the biological width of 2.5 millimeters. So this is the visual try-in. So at this point, we haven't done any tooth preparation. You'll see there's some shine through. And that's an area where we know that we're going to have to do a little bit more tooth preparation, but we still added to the front here. So we said to Shane, what do you think? And Shane says, that's great, I want to go ahead. And so now we'll get to our tooth preparation. Now, generally speaking, this for me is a separate appointment. Some colleagues advocate sending the patient away with the visual try-in. Pascal Magnier will often do that. Personally, I prefer not to. The most powerful part of the visual diagnostic appointment, without being corny, is when you take it off. Because patients, if they like what they see, then invariably will want to proceed. Again, it's not a sales technique, it's just a reality that you're giving back something they don't like and they prefer this. So if you've got it right, and the other thing is be prepared that you might need to recontour, you might have lengthened the teeth too much. Generally, I'll always ask the lab to add at least 0.5 millimeter. Why? Because it means I have to do less in size of ledge. That may be too much. So I may need to contour it. I may want to add some flowable to make it longer. If I'm recontouring this visual diagnostic, I will take, I might be changing line angles. I'll take a new alginate, I'll send that to the lab, I'll ask them to tidy it up if it's needed, then make a new putty, so that when we do proceed, I'm not having to make any of those changes again. So we'll now move forward to our preparation report. Now, if a patient's traveled, I actually will sometimes do this in the day, knowing that I'll explain to the patient, I would ask that you cover some of my surgery time if we don't proceed, but it saves you traveling again a long way. Different options. I want to give patients the opportunity that they don't feel that they have to proceed, but if you've got the smile design correct, invariably they're going to want to proceed. So here we've got a visual diagnostic. I've gone back to a slightly darker color for this because it helps me see what's tooth and what's not. And here, what we're doing here is we're doing depth cuts. What depth cut? 0.5 of a millimeter depth cut wheeled, and then highlighting that depth cut. Where I don't do any tooth preparation, you'll see as we move forward, is at the cervical margin. The reason is there's not enough enamel. So if you're doing a 0.5 depth cut there, you're already immediately, a lot of the time, going to be through to dentine. And invariably, if we do these depth cuts and just feather that into what I would call a micro shaft, barely visible. I do like to provide some margin. I don't do completely prepless. I'm going to ask that any questions we save to the end, because we'll probably get distracted. So I know that someone's raised their hand, but if we could ask you to hold that to the end. So the depth cuts being mid-cervical and towards the facial, not actually at the cervical. And this is the first case that I did this with. This is a technique championed by Gallup Gorel. I call it the Gorel technique. He's too modest to call it that, but I think he developed it. And then we'll do our incisal edge reduction. Now, I've got another case you'll see, but in fact what I do is I take my burr, I'll measure the thickness of my burr, and if I want to have a millimeter reduction, I'll use a burr with a millimeter diameter. Now, we're aiming for a facial path of insertion. So when we do our incisal edge reduction, it's very important that we have the burr angled to allow us a facial path of insertion. If we have the burr angled like this, we're going to have an undercap that commits us to an incisal path of insertion. So I will do a flat bevel or even slightly sloped bevel, because that's my preferred veneer edge margin. Now, I am going to be doing a hands-on program once lockdown finishes, and City of London Dental Schools have information about that. We'll cover all of this in preparation designs in a lot more detail, but we haven't got time to go into veneer design margins today. So we'll do our our incisal edge preparation. So the key here now is we remove, this is Luxatemp by DMG, we remove our Luxatemp. What we'll end up with are pencil marks where we need to reduce the tooth. And just to look at why we're in enamel, obviously, what happened is I was doing a lot of veneer preps that were originally taught it was okay to maybe do reverse 3/4 crowns, 3/4 veneer preps. Invariably, you're into dentine, and what I found is after about 7 or 8 years, some of these tend to start popping off. Why? Because we can bond to dentine, but it's not as durable as our bond to enamel. So I now want to be 100% enamel. And a veneer is going to be 0.5 millimeter thick. If we look at those, we can see that at the cervical margin, really often we've got less than 0.5 millimeter. So that's why I don't do any preparation cervically. So we take this off. Now, if we look here, okay, strictly speaking, the only place we need to do any preparation is where we have the pencil marks. Okay, that's how much we can be additive. Now, this was one of the first cases I did, and I still think I prepared it a little bit more than I need to. And nowadays, we wouldn't prepare that nearly as much, and I'd consider the degree of prepless. I do prepless. I prefer to have a margin because the lab, sometimes you'll find it difficult to get into some of these areas if you don't give them a smoother path of insertion. So some degree of tooth preparation, but again, minimal. I'm not advocating we can't prep teeth. I'm advocating that we do as little as possible. So here we see the left-hand side prepared, the right-hand side. This is where I nicked the gingiva, but with a hemostatic agent, we can stop that. A little bit of lasering. And again, I just think that maybe I could have done a little bit less reduction. But I know these are 100% enamel. So that's our before and after comparison. And that's why I don't think I maybe needed to do as much incisal edge reduction. But it's still minimal, what some people used to advocate. So here's our before and after. And if we look at the profiles, retracted views, again, there's no doubt this canine is a little bit wider. Playing with line angles, we can mimic, reduce the appearance of the width of that, and we can even maybe bring that a bit further forward. And you'll see from the occlusal views, the lateral views, that those canines are wider, but it works from the front. We've checked it works before we've done any tooth preparation. And you can see here how we have widened. Those have gone quite a bit wider. You may notice a little crack line here. It's an interesting case. There's a case that was done with a material Vita called VM9. Now, the problem we have is that Vita never acknowledged it, but they did discontinue it. That these were made, these are feldspathic porcelain made on platinum foils. And I can only think that there was some degree of contraction shrinkage the material couldn't accept. Because this was bonded in, and I was cleaning cement up here, I came back and suddenly this crack had appeared. Now, I advised the patient about it. I said it's internal, I don't believe it will be an issue. I will replace that at any point. I would advise not to replace it now, but if it stains in 5 years, I'll replace it, because if I'm going to replace it now, I would also replace it in 5 years. But I don't believe it will be necessary, and in fact, you'll see why. But I made the patient aware of it because I was aware of it. And so we have Shane at his final result. Now, my point about is how things move on. Shane moved to Australia. He contacted me asking if I knew a dentist locally, and I said, hopefully nothing wrong with your veneers. He said, no, everything is fine. I just need some routine dentistry. But how things change over time, that's Shane 15 odd years later, but we can see that everything now is looking as we want it to, including that upper left too. And Shane is still in contact. I'm delighted what we've achieved for him. I think a lot of time buccal corridor is overlooked, and that's a fairly well-known case. I know who did it. I've no need to mention that, but I don't know what they were thinking. They're not really addressing the buccal corridor. And in fact, one of the Friends episodes where Ross does tooth whitening was a Mickey take about the person that had done this to Matt Perry. But anyway, buccal corridor, we must always be aware of it. I'm not a big fan of 6 units, often because I think 6 units will look too bulky, but 6 units can work. So buccal corridor, patient many years ago, didn't like midline diastema. Again, slightly flatter smile line. I can see that the left-hand side buccal corridor is well developed, the right-hand side is. I'm concerned that when we've done this, this is going to be an issue for the patient. But I mentioned it in advance, and the patient said, that's not what bothers me. What bothers me is the front 4. So here we've done 4 units. And again, a little bit more noticeable about the buccal corridor here. I think it's as clinicians, our responsibility to be aware of that, maybe mention it to the patient. It could be treated, but it wasn't an issue for the patient. Slightly dark pictures, for which I apologize. 7-year recall and 11 years post-op. Patient delighted. The patient had some profile pictures made. She'd contacted me asking if I knew someone in the West Country who could look after her husband, who had a lot of wear and needed a rehab. And I suggested a colleague, and I think that all progressed very well. But the patient said, thank you very much. And by the way, I'm still delighted. Here's some profile pictures I've just had done. So sometimes patients don't always know what they don't like. So Ria here came through me, actually through the BACD Finder dentist, and she said, I know my teeth are okay, but I just don't like my smile. I'm not sure what it is. Now, I had a hunch it was her buccal corridor, but I needed to confirm that. So did a mock-up. There's a little bit of imbrication, and in fact we did end up pre-aligning rear with some aligners, but initially, before any alignment, we did some direct mock-up. So all I've done here is taken some composite and placed it. It really is, they're not a great shape, they're not perfect by any means, but that was enough for rear to say, yep, that's exactly what it is, that's what I don't like. So we then had her buy-in to move forward. We then did some pre-alignment, so the liners. I'll talk about retention when we get onto our section on ortho. And here you can see the pre-alignment uppers and lowers. She's actually missing lower canines, but not that noticeable from this picture. That's some edge bonding on the lowers, prepless again. And then here we've got her visual try-in. So we've aligned the teeth, we've done a wax up, and we've done a visual try-in for her again to approve everything. And then we've had the veneers made, okay? But we make temporaries. We still make temporaries so that we can do any contouring. And here, the patient, this is a visual try-in. We've done 0 tooth preparation here, and we've now made temporaries. And the difference is the temporaries are spot bonded in place. The visual try-in isn't bonded, but with the trial smile, I will spot etch in the mid-facial of the tooth. I'll paint on some unfilled resin, or in fact, I use Optibond FL 1 and 2, so I'll paint on number 2, cure that, and then shrink fit these on. The important thing with the trial smile is make sure the patient can keep it clean. So here we've got our try-in. Now, it's a great result. I use a number of different labs, Tony Knight, but this is done by Christo in Unica in London, but this is done by Hit Palmer at Fine Art. I think he's done a great job, but now I had some issues that I still wasn't happy with the what is in fact the 5, but we'll call it the first premolar. I didn't think they were wide enough, and I wasn't quite happy with the shape of the 3s. So we asked to make some modifications. Now, the patient then picked up on the fact that she didn't like the width of this lateral. So she said, can we do anything about that? So here, I've done a direct mock-up. These are porcelain veneers that try and they work fit. We decided not to fit them because I wanted to build these out a bit more, change the angles of the 3s. But we've done a build-up of the upper right lateral. It's too bulky, but it gives the patient enough. And the patient then elected to do an extra unit, and we felt we could do that prepless as well. So this is at fit. Rear is a vet. She's moved away, and so I haven't been able to get any post-op pictures. What we've got is 1, 2, 3, 4 units on the right, 1, 2, 3 units on the left. A little bit lower in value because these have dehydrated at the fit appointment, which this is taken. So again, a prepless case. You can see her fixed retainer. I will make her an Essex retainer as well. I never rely just on a fixed retainer personally, but I do prefer fixed retainers to just giving an Essex retainer. So that's why I feel 6 units can be a problem. It's not a case I did, it's someone that came to see me. But I think to remember that 6 units can work. So we have Kieran. Kieran is a rugby player. He's getting married. Sadly, he's no longer married to this person, but she encouraged him to come in and get something done before they're ready. I'm concerned that 4 units alone is going to make those front 4 teeth too bulky. So this is a visual try-in. You can see how we refined it a little bit more of 6 units. Why does that work? Because they're able to build the canines out and still flow into the well-developed positive buccal corridor. So again, I'm looking at 6 units. You say, Kieran, how do you feel that works? Sorry, this is not Kieran. This is Ben. Anyway, so how do you feel, Ben, about how that is? Absolutely, I'm happy to proceed. So again, using a similar technique, I tend to use a dark shade for the visual try-in when I'm doing the Durrell technique, because it helps me see what's tooth and what's not. And here, the reason I put this in is you can see this is how we do our incisal edge reduction, and then flattening that off. As I said, making sure we're allowing facial path of insertion. So our incisal edge like that, we're not going to undercut it. But with the shape of these teeth, we did end up having to do more nasal reduction than I would have liked ideally. So that's our foundation shade, and that's our final result. And we can see laterally, even though we've got big spaces, we've managed to keep everything in proportion. Here I'm doing slice prep, so the laboratory can have the emergence palatally and not have any black triangles. And so that is Ben before and after. Obviously, where his lip line works, lip line falls works for us in the point of that we're not seeing the length of these centrals. No black triangles, everything flows in very well. So 6 units can work, although they're not often, in my opinion, ideal. And that's Ben before and after. So I consider a visual diagnostic now mandatory before I'll do any tooth preparation. And hopefully you'll see why from this picture. So the patient didn't like a very large midline diastema. So we waxed up 10 units, and the patient, I'm not saying the patient's wrong at all. The patient said, I feel they're a bit small, a bit squat, a bit square. So we recontoured them a lot. So I lengthened them a little bit, I changed the line angles, I thinned everything down. And the patient now says, I think they're too thin and rat-like. And the reality is, I'm not saying she's wrong, okay, but she felt that they didn't look right. Now, there's very little place I have to go because I've done both extremes and she didn't like either, and she didn't like what was in between. What she really needs is orthodontics to redistribute that midline diastema evenly over the front 40 and maybe just 4 units. So we ended up not doing any treatment. If I had done any tooth preparation, I would find it difficult to get to a point where I think I could give her what she wants, and that's fair enough, but I need to know that I can achieve what she wants, otherwise no one's going to be happy. So orthodontics and 4 veneers to allow smaller teeth. Visual diagnostic, also very important. Here, visual diagnostic, we're looking at doing 4 units simply to match into what we have. The patient said, that's great, but I'm not sure I really need 4. Can we look at just doing 2? And the reason we're looking at just 2 is obviously shorter tooth, front tooth, no incisal dominant. I explained that I thought that would leave 2 teeth too big, but obviously that was something the patient could choose to do. And we showed him 2 as well, and he elected to do 4, and that's his final 4 units. Interestingly enough, patients do learn to smile again, and here he's not. So he's a little bit focused on his smile, but I know that he will learn to smile naturally. And another case just to demonstrate that. So Lorraine came to see me. She'd had pre-existing bonding. This is the last porcelain case. Pre-existing bonding, which had worked quite well, but she didn't like it. She had spaces. She wanted to see what was possible. So I said, okay, let's do a visual diagnostic. In fact, this is where it's very important that we know that we can contour teeth as we need to. The patient may not like what she sees. And in fact, another colleague, for various reasons, did the visual diagnostic, and she said she didn't like it and she wasn't proceeding. I said, Lorraine, would you come in? Let's have a look at it together. And in fact, we made some modifications at the visual try-in, which reassured her, because what she wanted to, she wasn't sure she wanted to close all the space. So here, quite an early one, a little bit less refined than I think we've achieved now. But she wasn't sure if she wanted to introduce spaces. So she said, can we put some spaces in? I said, yeah, sure, we'll put some spaces in. This is in the visual try-in, so no tooth preparation. At that point, she realized that actually we could make changes. And that's what she hadn't appreciated before. And so she said, right, I'm fine. I know we can achieve together what I want to achieve. Can we proceed? So this is her with her temporaries, quite big, making sure the patient can keep things clean. I want to be able to pass the TP through here. And so this is at preparation. I've already contoured them a little bit better. I think they're a nicer shape. This actually is a case of 8. I still would have preferred 10, but we can get away with 8, although that, as I've said, for me, I think is fairly rare. So this is at tooth preparation. And Lorraine says to me, right, can you put those spaces in? At which point I say, no. I will have spaces in, but I want you to live for a week with them as they are. And she said, okay, that's fair enough. So she comes back, and then we put the spaces in. Contoured as she wants. And I said, Lorraine, from here on in, once I put them in, it's absolutely your choice. You decide what you want to do. And she comes back a week later, or we speak, and she says, no, actually, I think you were right. I don't want the spaces. So we take Lorraine to here. These are early Emax veneers. we've got some great incisal translucency, and that's the 4 units. Sorry, the 8 units. And my point about is how patients learn to smile. So at her 8-month recare, and this was when I was traveling to Scotland, I'd moved from Edinburgh to Glasgow. She came to see me in Glasgow. But 8 months, she came from 8 months recare in Edinburgh before I'd moved. And then a few years later, she tracked me down and she comes. Now, the real difference here is the veneers look exactly the same. My point is, all I've said in the 2 photos is smile, okay? And at 8 months, she's still a little bit conscious. 3 months later, 3 years later, she's now very comfortable with her new smile, and that's a much more natural smile. So I think patients will, when they're comfortable with what is on display, will learn to smile in a natural way. I think we mustn't forget that we're in the digital age now. We were doing a surgery case with a colleague, a CD2 who travels from Cardiff, Mike Fuse, looking at this case, and he said, you know, I think I can do those digitally for you. So he did a digital wax up, and with his zircons on, he milled these PMMA acrylic shells. So at this point, again, a prepless case, I'm putting this on patient just to show what can be achieved. For the patient, it's so they can see it. It's also for me to make sure that I can achieve 4 units and not make these teeth too bulky, because if we look at those spaces, I'm thinking, are we going to be able to achieve that? And it shows that actually we can. Apologies for the full face shot. These are 4 prepless, completely prepless veneers and transform this young lady's life. Again, apologies about the focus on the full face. So what about limited treatment orthodontics or anterior tooth alignment? I'm not getting paid by SmileFast, by CFast. SmileTrue are their digital aligners. As I've said, it's the brand I use. There are many brands out there, whatever you feel comfortable with. But I do believe that really we should be treating within our I'm very happy for GDPs to do orthodontics within their skill set. The issue is that if you start moving more than just the anteriors, so basically 3 to 3, you're more likely to disrupt the occlusion. So into premolars, posteriorly will interdigitate like this. If you move an upper premolar, you have to move the lower premolar, you have to settle the occlusion. So you're more likely to disrupt the occlusion. Now, CFast, we treat just 3 to 3. So we won't aim to move the premolar region. We'll have bracket brackets set up. We won't do IPR past the 3s, which more we feel is you're less likely to get into difficulties. If you have the skill set to do that, then by all means do more comprehensive orthodontics. Everyone I do CFast on is offered comprehensive ortho as an option, because there's no doubt that anterior tooth alignment is going to generally introduce certain compromises which we need to advise the patient about. But the difference is I'm looking at doing a case in 4 to 6 months, not 12 to 18 months. And so if a patient is happy to have aligners for longer, or alignment for longer, orthodontics for longer, great. But many adults aren't, but they can generally sum up the idea of 4 to 6 months. We do run courses. The course is not to teach you to be an orthodontist, it's to teach you case selection of what can and can't be done. But no case will be approved by the lab if we don't think it's possible. And also we will advocate imaging in advance, and there is a forum where you can get support as you go along. Obviously, we can't teach you to be an orthodontist on the weekend, but we can open your eyes to what's possible. Personally, I will do labial, I do lingual 3 to 3, and I will lose aligners. I prefer fixed if possible, but if a patient won't let me put fixed on, I will use aligners. I'm Invisalign certified. It's a very clever system. I also use SmileTrue aligners. Why? Because Invisalign can be quite expensive if you're not a bulk provider. If we quickly look at how it works, so we've got brackets and wires, brackets, and rough description. Initially, up by a slot. Tie wings, if you're using elastics, again, we're not really having to use elastics much because we're not really changing the occlusion. Arch wire slot. An orientation dot just tells you which way round the bracket goes. Bracket hook if you're using elastics. This is our self-ligating bracket. With this, the wire is held on by an O-ring. The O-ring will and often does discolor. Yes, you can use ties, little metal ligatures, but they're more time consuming. So most people will use elastics, and the elastics discolor. The advantage of self-ligating is this has got a gate that closes up and down, and that keeps the wire in the slot, and so there's no elastics. So we're not getting any discoloration, less limitation on what the patient can eat food-wise. So that's red wine and curries generally. So then we have our arch wire. Again, very briefly going through it. There are courses which will take you through this. The wire wants to be a perfect C shape. Wire attached to the bracket, takes the bracket and the tooth with it. Bracket positioning is done on an indirect bracket model. So you have these carriers, so you're not having to worry about bracket position, although we will talk about that in the course. I say I do lecture sometimes for CFAST, and so out of habit, I feel part of that CFAST family. So what movements can we do? Really the same as any conventional bracket. The tooth and the bracket don't know that we're asking them to do less. So we can do tipping. The important aspect here is it's not the root apex, so we are just tipping. We can do a bodily movement. We can do intrusion. We can do extrusion, and we can do rotations. What we can't do is we can't do root torque. And why? Because we're only using round wires. Again, if after the 6 months you want to step up to a stiffer round wire and then use a rectangular wire, you can torque roots, but we're not generally finding it's necessary, and it will add at least 3 months to the end of the treatment. So what do we mean by root torque? So here we've got a patient with an in-standing lateral and crossbite. That's the tooth tipped, not root torqued. And by that you can see that it's flared, okay? And the flaring can be an aesthetic compromise, whereas if you torque the root out, you're going to have less flaring. In fact, this is Bijou's case, but it just demonstrates that often even that compromise is not an issue, because compared to where the patient started, he's fine with that. TIF, friend of mine calls it ABB. I prefer ABC, align, bleach, and correct with composite or ceramic, often minimal prep or practice. I do think it's important we point out to patients in advance that some degree of possibly bonding or even ceramics may be necessary, and I'll tell them what the cost would be. That's up to them whether they do it. So here, Alba. Now I've shown this case to orthodontists, and they said they don't believe that took 7 months. Well, it did. We use bite stops, but not to open the bite up. If we're using this, the tooth will come forward edge to edge, and then come into a positive overdraft. However, what we'll often use bite stops for is fooding on the brackets. So yes, we'll use bite stops, generally Fuji 9 on the 7s, but not to help us open the bite. That's just to help patients stop biting on the brackets until they're in a more favorable position. So here we've got the case at 4 months, already pretty much aligned, but we still want to improve the overjet. We're bringing these forward. We're doing more interproximal reduction, tooth slenderization. That's allowing the spaces between the lowers, which as we close them is going to bring them in, and that's going to allow us to achieve a class 1 occlusion. I knew this was going to be a teaching case. This is before we had self-ligating brackets, so this is O-ring. And this is actually a case where I did use elastics because I wanted to settle the occlusion. But generally, that's something that I was able to do because I had more experience. And so this is at Devon. Now, we could have spoken to her about icon, about whitening. I'm honest, she was delighted with the end result and felt that nothing else was required. And you can see what we can achieve. And I'm going to show you a number of other cases quickly just to show you that. How long do I need to wear a retainer? Again, another good friend of mine, Asif Chatu, taught me this. The answer is as long as you want to retain a result. So how long do I need to wear a retainer? As long as you want to retain a result. Long-term retention is essential. 60% of the CFAST I'm doing is relapsed adult ortho, either because they weren't given adequate retention or it wasn't stressed enough. Now, I think that's changing. but we need to be responsible and let people know. Our choices could be just to give an Essex, and if patients have worn aligners, they're more likely to be happy wearing an Essex long term. I'm not sure it's reasonable to ask removal for the rest of their life when we can give them a fixed retainer. This can be done indirectly on a lab jig, or I tend to do it directly. Why? Because I know how to. It's not difficult. There is a learning curve, as with everything, but I can do it directly. It saves a visit. And here I will then make an Essex retainer over the top. My advice will be to wear that Essex every night for the first 6 months until everything is settled, and then a couple of nights per week. If the retainer comes loose, the fixed retainer, if they wear the Essex at night until I repair it, then that's fine. The problem is sometimes the retainer comes loose and they don't know about it. So I advise them it's a good idea to wear the Essex a couple of nights a week, or at least try it in once or twice a week to check that nothing's moved. And that's Alba. Now, some very quick examples. I'll tell the patient we've got some differential tooth wear. She might want to consider some edge bonding at the end of the result. Here, that's the post-op, and we did a little bit of tooth whitening, a little bit of edge bonding before and after. This is a lingual case. I was working in the West End at the time. A patient had come in and said, "Can you veneer my teeth?" And I said, "I don't think you need veneers. What if we pre-align them? Because I'm going to have to take much less tooth away. That I won't have to take any tooth away." So this is her occlusally, not the best lower shot, apologies. This is not her, but this is the lingual brackets that I use. Again, self-ligating, a little catch here that lifts up. And that's her before and after. So that's her aligned. About 3.5 months. In fact, I find lingual, because of the radius of the arc, actually happens to me quicker than labial. Was a well-declared footballer's wife, and she wanted to go white. So we bleached her for an extended period of time, 4 weeks. We did a little bit of icon just to reduce the white spot lesions to a point where fixed retainers, very happy with the end result, 0 tooth preparation. So for Megan, I originally thought maybe this was a buccal corridor issue, but in fact it's not. Now, I think if you've got posteriors that don't meet, then moving the buccal corridor is less of an issue. And if you're happy with occlusal equilibration and minor refinements, yes, of course you can move the buccal corridor. For Megan here, there is a little bit of that, but really it's more about tucking in those threes. So here we can see the anterior misalignment, a little bit of instanding in the premolars. Again, before and after, again, 0 tooth preparation. Afterwards, just tooth whitening. She didn't need any edge bonding. And how many times in the past might we have lifted a drill to try and do what was referred to in the early 2000s as infant ortho? Doesn't have a place, in my opinion. And here's Megan close up, a perfect classic smile design on her natural teeth. And that's her fixed retainers. She has Essex retainers over the top. We can do more complicated cases. Rupert has an instanding upper 3. Certainly not one of the first cases you do. It's a complicated wire sequence because we need to be piggybacking. We're using a stiff wire on the outside and a more flexible wire attaching to the 3. But again, within our 6-month time frame. Rupert, very happy. That's his canine brought out, bodily movement in a 6-month time frame. He had whitening. He's not been committed enough to do and complete the whitening. I work around Abbey Road, NW8, Abbey Road Dental. He's local. I see him walking around. He says, "Yes, I must get on with my whitening." He's very happy with how this is, and so hasn't proceeded. The plan was also to do a little bit of bonding here, possibly on the laterals, but again, he's happy. Here, originally I would have said I thought this was a two-size discrepancy, with the ones being too big. In fact, it's just because the ones are prominent, the twos are set back. And if we do some alignment, okay, they're still a little bit dominant, but nothing else was needed apart from ortho. Fixed retainers again. Again, this is sometimes how quickly things can happen. We need to be aware that we can potentially have black triangles. Certainly when Got an older patient with cross centrals, often we'll see them here. We're lucky it falls beneath the lip line. There are ways we can deal with that. One is with the, used to be called the Clark matrix, the BioClear, has a place. Often I feel the teeth can look a little bit too round. So often now I would be considering further IPR here to change the contact point, make these less triangular, straighten them and squeeze together. And in fact, you can see how that can happen here. So patient's main concern here was actually flat triangles. And if we slenderize the teeth, so we make them less triangular, make them more rectangular, we can change the contact point and bring the teeth in. So patients had CFAST to align, but also we've managed to squeeze together and eliminate all her black triangles. So now we're moving on to more of the realms of direct composite. So dial concept, a big influence for me, because here his wear is 3 to 3. Now this was done with a vacuum formed stent in composite, really because I wasn't comfortable building in 3 to 3 in porcelain, because I felt that we may have some, it might be putting too much force on that. So we built this up. Now this was before a newer technique that I'm going to show you, which allows us to do all the veneers, the composite build-ups together. This was done with a 4mm suck down stent, and I would do individual teeth, or in fact at least alternate teeth. So you could do the 3, the 1 and the lateral together, and then do the 3, the other 1 and the other lateral together. The only issue here, and this is the final result, I'll show you the build-ups in a moment. We built him up just 3 to 3, excluding posteriorly. We know that in a period of 4 to 6 months, the posteriors will supererupt, the anteriors will intrude, and maybe some remodeling, TMG. And we're going to review that because we might need to do some equilibrations to check that we've got favorable long axis loading of the teeth, but we know that we can re-establish the occlusion. I'm honest here, the issue with the lowers is I hadn't treatment planned this correctly conceptually, so I hadn't done an upper wax up, sorry, a lower wax up. So in fact, the lowers I built freehand, which I wouldn't advocate, but can be done. The lowers are just edge bonding. The uppers are more like full coverage with some latent coverage. And so we needed to do the lowers to establish the occlusion. Here you can see how I've done alternate teeth, and then that's all the teeth together. So moving on, these were done direct, 4mm stent. Some good friends of mine, Midday and Tom Seeley, have developed SmileFast. And SmileFast is a way of doing composite veneers. I'm not involved with SmileFast. I'm currently, apart from I think it's a great system, a great idea. What it is a heated stent, heated composite with separators in. So all the veneers can be done together. I would explain to patients that we're going to have a few different options at the end of their treatment, or at the end of their treatment if they've had CFAST, or even before they have the teeth are aligned. It might be that they're amenable to edge bonding. To give you an idea of cost, for me, edge bonding, you're looking at about £250 a tooth. I can talk about porcelain veneers, about £1,100 a tooth, longevity 10 to 15 years. This falls between the two. It's about, I'm going to say longevity of 5 to 7 years, and about half the price, about £550 a tooth. And it's just to give you a comparison. The thing about direct composite veneers, they've always been possible, but they're difficult to do because you're directly layering on the tooth. And this solves a lot of those issues. So a heated composite stent with relief channels, developed by, better known as Midday, I don't even say his full name, by Tom Seeley, because they thought there was a better way. Now they've both got excellent hands. They can both do direct composite veneers, but they know that not everyone can. So really, separate protocol, except the wax up is done digitally, and this is the final result. But we'll go through the same protocol. What we'll have is, and these, I have got cases in the go, ready to be done after lockdown, but these are Tom and Mide's cases. That's a before and an after, sorry. Yeah, that's the after. And generally, they would say 4 to 6 units. From everything I've said, I'm preferring 4 units. 6 units can be done, but I think you need to be prepared. You might need to be doing some buccal veneers of the premolar region to build things out, because sometimes they may be too bulky. So we're using heated. They've chosen Empress Direct. This is a new composite heater that Conor Bryant of Bryant Dental has developed, he's developed it as a composite heater, which is also good for local anaesthetic cartridges. He has done a CFast adaptation to allow the stent to sit in there as well. And so this is a case that we'll go through. They have obviously diagnostic, you can see the wear, previous composites. So digital wax up of 6 units to produce, and that's where we can see how much we're adding. And so what they can produce is a digital wax up, and they will print a 3D model and a V-notch putty. And so this is we can do before we start a visual trial, before anything happens, and confirm the patient is comfortable with the result as I've advocated. They would then do any tooth whitening that they feel necessary. Now, generally with porcelain, I tend not to whiten the teeth. I'm going to put porcelain veneers on because the result I feel may fade over time. And if you've got a covering on it, then that is more likely to maybe shine through. However, the composite we're using here is probably going to be a lot thinner than we're using for the porcelain build-ups. And so generally we would whiten the teeth first and then do a try-in, check the patient's happy. I'm glad I'm not the only one who doesn't always remember to clean up the alginate before the pictures. Patient consents, we can do the whitening. The patient whitens for however long, happy with the result, with the color-wise. And in fact, the protocols is that there is a charge for this, which doesn't include the charge of the stent. But if the patient isn't happy, similar to how I've shown earlier, patient just pays for this stage and doesn't proceed. Then they will make the stent. The stent, I think, is about $350, slightly less for 4 units. Patient whitens, and then isolate with, so we're using local anesthetic. This is Teflon tape, PTFE. Isolate the gingival. The heated composite goes in the stent. Completely etch the tooth, goes in the heated stent. Cured, flow excess. Again, there's a course on this. I'm not going to try and teach it now. Just want you to make you aware of it. Look at this surface texture. This is straight when the stent is removed, okay? So that we can achieve the same aesthetic results that we can achieve with porcelain, but at less cost to the patient, but obviously less longevity. This is the excess, finishing very important. I'm going to remove the excess, remove the PTFE. Yes, it's traumatized, there is local anesthetic. That's how it is, okay? So that's the final result. And look at the texture. Now, again, on the course, they will talk about adding surface texture, but because it's a digital wax up, often that isn't necessary. So, and to give you an idea of what Smile Fast is, again, a wear case. So we're nearly finished now, but just a couple of others. So what do we do about a gummy smile? Gummy smile, for me, really, we need to first of all look at tooth proportions. Now, these teeth have width to height ratios a little bit more than the 75 to 80% we consider ideal, probably about 90%. So we know we can do some crown lengthening. We cannot crown lengthen up to here because the proportions will be too long. So because this is going to involve osseous crown lengthening, I haven't raised the flaps since 1995 that is, but I work with a tag team, so I'll either have my surgeon in-house. Basically, I will be responsible for lasering to the ideal gingival margin. So I'm creating the profiles that I want. And the biological width, we know that we will invade when we do that, but we plan to raise a flap, change the osseous contour, and replace the flap, effectively recreating the biological width. So I will numb the patient, I will laser for the ideal, and then I will ask my surgeon to measure from the incisal edge to my new gingival margin. If I'm working with a periodontist and the periodontist isn't in the house, as long as that's scheduled for a few days or a week later, biological invasion of the biological width doesn't happen overnight. It's a process of inflammation. So there's a little bit of time where the patient goes separately to the periodontist. You can ask the periodontist to contour the gingival margin to where he or she feels it should be, but as the restorative and the cosmetic element in the team, I want to be responsible for that. So I'm going to decide where that goes, and then I'm going to measure from the incisal edge to the new gingival margin. A surgeon's then going to raise a flap, and he's going to put the osseous crest 2 to 3 millimeters higher than the new gingival margin, and then replace that. So I think here, hands up, I did this. I've maybe made them a little bit on the long side, but only fractionally. We've managed to still keep the zenith in the right place and keep the central slightly longer. But that's probably more like 70, 72% than 75 or 80, which is why they're a little bit longer. But at this point, that's improving the situation, but she still has a hypermobile, a small upper lip that has some degree of hypermobility. So as discussed in advance, we said that that would be the first stage, and she can elect that that's enough. But if she wants to go further, at this point, I would suggest to her that the first thing to try would be Botox. Botox will stop the lip moving as much and can demonstrate to her what can be achieved. She can then have that Botox repeated every 4 to 6 months if she wishes, or she can have a procedure called a reverse frenectomy, where effectively it's getting a little bit more scientific. You're taking out the attached gingiva and effectively sewing the lip down so it doesn't move as much. And this was done by a colleague, Peter. I think he would agree that he might have been able to do a little bit more, but it's not easy taking this unattached gingiva. It's like jelly. And I think if we look from where we started to where we finished, it's an acceptable result. She could have the reverse frenectomy repeated if she wished, but she was actually very happy with how we've managed to reposition that. Another prepless case, Dana came in, she'd had some bonding, and she said, can you just refresh my bonding? And I said, yes, I can refresh the bonding, but I'm concerned that if we do that, these laterals are going to be a little bit too wide. And she said, that's fine, but I don't want my teeth touched. I don't want any tooth preparation. I said, okay, well, let me show you what we could achieve if we were to look at doing course. I did 4 units additive. And what really gave it away is she said, well, you know what, apart from the spaces and the discolored bonding, I've always felt my teeth were a little bit short at the front. So at which point, light bulb moment came on for me. Can we do 4 units prepless? So I waxed up 4 units and I waxed up the 2 laterals to show her what it would be like just to do the bonding. And this is her visual try-in for the 4 units, okay? And you can see how we've evolved this now, where these are not spot etched, they're just, it's bisequil, so it's Luxatemp, it's just shrink fitted and shows her the end result that's possible. She said, that's great, if you can achieve that without drilling my teeth, then I'd like to proceed. So here, what I've done is I've just soft flexed off the previous composite. And other than that, 0 tooth preparation at all. She had, this is her natural tooth shape, believe it or not. She was adamant she'd never done any tooth whitening. She certainly didn't need any. And so that's her, again, at fit. I've done no tooth preparation. This is from the cleanup, and here is from her using TPs during the trial smile phase. Can't introduce the black triangle, and that's her before and after, and that is another completely prepless case. So for me, minimal intervention is essential. I think it's important though that we don't underestimate of how powerful some of these treatments can be. Sue came to me and still comes to see me. Sue came to me 15 years ago. I'd like a little bit of whitening and maybe some to replace some of these fillings. I said, Sue, there's a lot more going on than that. And so Sue turned out to be a full mouth case. We reorganized her occlusion, testimonials from her, where we've eliminated her, we've reduced her migraines to 2 a year from maybe 4 or 5 a month. and her pretty much constant head and neck pain. She was overclosed, she had wear, she had no anterior guidance. Again, is occlusion important? Absolutely. Not a presentation to be able to go into detail on that. But for Sue, that's her front case. We've opened her vertical up. A lot of these pre-existing heavily restored teeth, you can see some of the posterior wear that's happened, but from a patient's perspective, all she's had done is her teeth, and you can imagine how that can be life-changing. So really, I would encourage that we can get some great results, but it's our responsibility morally and ethically to do as little as we need to our patients' teeth to achieve that. And hopefully I've shown that there are many modalities that allow us to achieve that.